Post-stroke shoulder pain is absolutely the most common barrier to restoring arm movement after a stroke, and is probably the most confusing and oftentimes overlooked challenges that most stroke survivors face. And to make matters worse, the response by the medical team isn't necessarily to solve the problem, but to medicate it. And so in this video, you are going to learn the actual root causes to your shoulder pain, common myths or misconceptions or ways that it might be being mismanaged by your medical team, and of course, practical things that you can start doing today to decrease your shoulder pain and, more importantly, start restoring normal shoulder movement. If you're new to this channel, I'm Tara, I'm a neurologic physical therapist, and on this channel we talk about anything and everything related to mobility, health, fitness, and mindset with the end goal of empowering you with as many tools as possible to take full ownership of your rehab and your overall health. And I can't think of a more important topic or a topic that I'm more passionate about than post-stroke shoulder pain. For one, probably because I've made a lot of mistakes when treating someone with post-stroke shoulder pain. And two, I see patients on a consistent basis where their shoulder is just not being managed appropriately by the medical team. And the most important reason for this is you cannot fix a problem before knowing what the problem is. And so let's first just go through what some of the most common causes are of post-stroke shoulder pain. And in my opinion, this is the very point where in many cases, your shoulder pain isn't being managed appropriately, as no one is going through and figuring out what the root cause actually is. And the number one most common, well, maybe not most common, but one of the common causes of post-stroke shoulder pain is a subluxation. So what is a shoulder subluxation? A shoulder subluxation is when the arm bone drops out of the socket. The way that you know you have a shoulder subluxation is you'll see a little divot on the outside of your arm, and that's just because the ball has kind of fallen out of the socket a little bit, and so you'll see a little divot where there's that little bit of space between where the ball is and where the socket is. Sometimes this causes pain, primarily because usually the structures around the shoulder that give it stability are compromised, and so you end up with other types of orthopedic injuries because of that. Second most common cause, or these aren't really in any particular order, but the second cause on the list is shoulder impingement. So we're not going to go in depth because I've done full videos on all of these root causes, but very simplified, shoulder impingement is pain with overhead reaching, usually because you've lost some of that scapulohumeral rhythm, and you'll hear that word a couple of times, but it's just a fancy way of saying that the bones that are involved in the shoulder motion are not in rhythm together. So you have the shoulder blade on the back and you have the arm bone, and they kind of move in rhythm together. So for every so many degrees that the arm bone moves upward, either abduction or flexion, the shoulder blade, the scapula, the large flat bone on the back of the shoulder, also moves. When you lose that rhythm, sometimes you've got the arm bone moving and the shoulder blade's not moving, or a combination of some sort of dysfunction with the mobility or the motion of that ball in that socket. And in most cases, generally speaking, it might ride up a little bit high in the socket. And what that does, there's nerves that kind of run over the top of the shoulder, and this is extremely simplified, but basically you kind of bang into those nerves a little bit. That's what we call impingement. Now, impingement is a very general term, and there's a lot more that goes into it, but big picture, you've lost that nice glide inside that socket, and you're impinging on some nerves that run over the top of the shoulder. Usually you'll get pain in kind of the front of your shoulder with any type of movement upward, in particular if you get up past shoulder height. Impingement is very, very common for people that have a lot of elbow flare. Okay, so when the arm is internally rotated, there is going to be some impinging on those nerves. What normal is we externally rotate this arm a little bit when we move it up, and that kind of clears those nerves a little bit better. So A lot of times I see this with those of you that have that elbow flare. Another big one that oftentimes gets mismanaged or overlooked altogether is adhesive capsulitis. And very simplified, and I've done full videos on this, so I'm going to keep this very brief because I know a lot of you have seen those videos. There's basically like a capsule that sits around the shoulder joint, and what adhesive capsulitis is, just like the word sound, it like kind of adheres or it shrinks a little bit, and so you just have less space for that ball to glide nice inside that socket. It starts banging into things. You get a lot of pain in some of the soft tissue structures around the shoulder. Again, I've done full videos on frozen shoulder, but typically you'll get pain in all directions. The other thing that I find is very common, which I've seen a lot recently, that might indicate you have frozen shoulder is if you have good elbow movement and good hand movement, but you can't move your shoulder in any direction, either because you feel like it gets stuck or because you have pain, usually that's a sign that there is something going on, i.e. this frozen shoulder, something with the capsule. Why is that? Because typically if it's related to a lesion in the motor unit that controls the arm, when you're getting that movement back, usually restore movement proximal to distal. And so that would be usually at shoulder first, then elbow, then hand. So if you feel like you have pretty good control of your elbow and pretty good control of your hand, but you can't move your shoulder, that's not going to automatically mean you have adhesive capsulitis or frozen shoulder, but that might be one indication that it's not neurologic. And then another big one, and this is the one that I think everyone just in the healthcare community just immediately gravitates towards, and I'll get more into that when I get into the medications, but is spasticity related postural changes. So what is spasticity? Spasticity is an involuntary contraction that is a result of damage to either your brain or your spinal cord. That involuntary contraction usually will rotate the arm inward, so the muscles that rotate the arm inward get some of that spasticity. The muscles that pull the scapula down and forward can potentially have that spasticity. And what I'll also throw into this category is abnormal synergy patterns, which I talk about quite a bit on this channel. When muscles link up abnormally together, that really impacts that scapulohumeral rhythm. And in most cases, you're either going to get that scapula pulling upward and backward or down and forward. And you'll just get all kinds of muscle and soft tissue imbalances that could create pain. The other one on the list is complex regional pain syndrome, and this is extremely common. So complex regional pain syndrome is pain that occurs, that becomes chronic, that doesn't necessarily match with the kind of volume or level of pain that should occur with certain movements. So the pain is amplified, in other words. Now, this can be caused because you've actually had a stroke in an area of the brain that perceives pain. So let's go back to the basics. Let's not forget pain is a very important thing. It's a warning sign to our brain that there's an area of our body that we need to focus on because something is being damaged. What usually happens when we have that discomfort is we do this little brief assessment, or our brain does. Is this something that I need to focus on, or is this not something I need to focus on? If it's not something that you need to focus on, then your brain will kind of ignore it. This is extremely simplified. Pain is very complicated. Think of it this way, that whole system is messed up. So either your brain's perception of that pain is not accurate, or you have some memory of having pain associated with that same particular movement. And so you go without moving it, then you move it again, you have pain, that memory increases. So now your brain has permanently kind of associated certain arm movements with pain. And so that alarm signal gets turned way up, that volume gets turned way up, and then it turns into something that we call complex regional pain syndrome. Okay, so it's some misinterpretation of the discomfort that you're feeling in your shoulder that gets amplified. Some signs of this is you will have some discoloration in your skin, you could have some swelling, your arm could feel cold. Now, those could also be symptoms of just having a stroke. So this is why it's so important that you work with a clinician who is doing this thorough investigation as to what potentially could be causing your pain. There are some diagnostic tests that they can do that can help to determine whether or not this is complex regional pain syndrome or whether or not some of these physical symptoms that you're having, coldness, swelling, is just a result of your hemiplegia. And then the last one that I'm going to talk about today, there are more. You want to make sure you see a clinician so they can rule out your neck, rule out other potential root causes of the pain, but is tendonitis or bursitis. So this is extremely common just because your arm isn't moving the way that it used to, so the muscles are not lined up correctly, simplified. We have bursas that sit underneath our deltoid tendon, so the tendon is what connects the muscle to the bone. We have little bursas throughout our entire body that protect that tendon from rubbing on the bone. A bursitis is just when that bursa becomes inflamed and can become painful. Now, I recently saw this in someone that wasn't diagnosed with bursitis, but I'm thinking it is bursitis, because his pain moved. Like early on in his rehab, his pain used to be lower down, and now he's really pinpointing it a little bit higher, a little bit closer to where that bursa sits, and it hurts when I push on it. So that's just one simple way to determine whether or not it's a bursitis or whether or not it's something else, but it is extremely common. But that said, many times, especially when it comes to the hip after a stroke, doctors automatically assume it's a bursitis because maybe they've seen a lot of stroke patients that have had a stroke that have bursitis, but they automatically start injecting someone without really doing like a full workup. So again, don't self-diagnose. The whole point of this video is that post-stroke shoulder pain is extremely common and it has a ton of different root causes. You really want to find a medical team who is committed to getting to the root of the problem. If you don't know what the problem is, you can't fix it. And here is the most important point of this entire video is this next segment, and it is a medical system that is medication first. They just start throwing pills at you or injections. That's what I'm calling medication first treatment. And this is a true story. I've had a patient recently who came to me. He has real pain. So what does he do? He goes to his doctor and immediately gets put on a cocktail of gabapentin, baclofen, and a muscle relaxer. And so my first question is, well, what's causing your pain? And his response is, I don't know. I'm like, well, what does your doctor think's causing your pain? He doesn't know. And I'm dumbfounded by this. Sorry for that word. I don't really even know if that's the appropriate word, but it's completely nonsensical. So he got put on 3 medications and the doctor does not know what's causing his pain. So let's break this down. Gabapentin is for nerve-related pain. So it's great if you have complex regional pain syndrome, but in my opinion, pretty much 95% of my patients are on gabapentin. That is not an exaggeration. So I think doctors just throw that out there regardless of why you come into their office. But that's a hot take there. Baclofen is for spasticity. Muscle relaxers, how to relax the muscles. Baclofen is great for spasticity, but it's not going to do anything for adhesive capsulitis or a bursitis. And all of these medications have side effects. So, true story, he went back to his doctor, said it was causing wooziness, still no assessment of the shoulder, just told him to take less of the medications. And so I want to be very clear before I make these next couple of statements. Medication is not evil. That's very important. Number 2 is I am not a medical doctor. Please work with your medical team when it comes to anything medication related. But here's my 2 cents. Medications are great if your pain is so severe you can't move your arm at all or it's dramatically impacting your overall quality of life. Absolutely, medications can be a great tool. And every medication has a side effect. And your doctor is very motivated to get you out of pain. So, what does that mean? It means if you go into your doctor and you tell them you're in pain, the first thing they're going to do is start throwing medications your way to get you out of pain. Where you can be involved in your healthcare at this point is do your own cost-benefit analysis. I think many times most of you go to your doctor and they say, what's going on? Anything wrong? Anything you want to talk about? And so, of course, you bring up your pain, but just be aware that when you mention pain, they're going to get their script pad out and start writing scripts. You might want to not stop there, but explain a little bit of what's causing your pain, but also in your own decision making, is the benefit of the pain medication worth the side effects? So even after they write you those scripts, do your homework, look the medications up, look at the side effects. Is it just that you're having an aggravation at night? And no, that doesn't mean you need something to help you sleep at night. Definitely see that quite a bit as well. But is it just an aggravation? And can you still do your rehab and still sleep okay and still have an overall good quality of life? Well, then maybe you don't need that medication. Because again, look at the side effects. There are side effects to that medication. And more importantly than that, pain is not something to be numb. It is a signal that potentially there is something suboptimal in your body or in your system that needs a little bit of attention. And maybe just by giving it that little bit of attention and getting to the root cause of that pain, that alone will decrease that alarm signal, i.e. the level or the volume of the pain you're experiencing. And that all begins with your therapist and your doctor, and hopefully my suggestion is a physiatrist can come in and ask the right questions, do that thorough assessment. Is it adhesive capsulitis? Great. There's diagnostic tests that you can do for that to rule in frozen shoulder. More importantly, and this just happened with a patient that I had seen, he got an injection into the shoulder, which, very simplified, kind of creates space in the shoulder, which can reduce pain. For him, it helped with his shoulder pain. Now, the evidence or the research is a little mixed post-stroke. It seems to have some short-term benefits, but there's an example of where gabapentin wasn't helping him, baclofen wasn't helping him, muscle relaxer wasn't helping him, and a simple saline injection is what did the trick for him. But if no one is asking the questions, you're not getting to that root cause of the problem, and so you're not getting to the right solutions that are actually going to get you out of pain and restore function. If it's spasticity, my sensical or logical brain tells me that, yeah, maybe they try baclofen, maybe you go back to your doctor and you tell them that that creates some wooziness. My logical brain tells me if a doctor is really doing this root cause analysis, that their next step would be to offer Botox. Now, I'm not saying whether Botox is good or bad. I think it helps with some people, but there's a lot of people, that it doesn't help with. My point being is that makes logical sense to me. A doctor has done a root cause analysis and they're staying in this spasticity bubble and trying different combinations of interventions to address the spasticity. If it's impingement or a bursitis, my hope is that your doctor says something about physical therapy. Of course, I'm a little bit biased. This is what I do for a living, but there are things that we can do in physical therapy to help with those things, as well as frozen shoulder. So I think for all of these, if your doctor is thinking or has a thought process, they're saying, I want you to go to physical therapy to work on XYZ, or your physical therapist can help you with XYZ. That would give me more confidence that the doctor is doing this root cause analysis. They are explaining to me that physical therapy would be beneficial before a whole cocktail of medications, and they're telling you why physical therapy might be important. So maybe they're explaining the structures to you, something along those lines. But again, none of that happens if you are taking a medication that is just going to numb the pain. But now let's talk about what you and your caregivers can start doing today to get you out of pain and start restoring your arm movement. And one and most important, which is going to help with several things on that list that we went through, is positioning. So if you have a shoulder subluxation or you have complex regional pain syndrome, sometimes that can be minimized if the arm is supported and in the right position. So when you're sitting, you want to kind of keep that elbow or that arm supported so it's not the weight of it's not dropping out of the socket. One thing you want to stay away from, and I've done videos on this, is immobilizing it, like putting it in a sling. Not beneficial, really not helpful. It's just gonna create some more what we call learned non-use. So when you're sitting, yeah, have some pillows under your arm to help support it. When you're standing, something called a give more sling can be beneficial. A give more sling works if you don't have a lot of spasticity. So it basically, with your arms straight, it kind of supports underneath your hand, so your arm still has freedom to move around. But if you have a lot of spasticity and your arm has a tendency to bend up, then that becomes useless because you're not getting that you're not getting that force through your arm pushing it back up into the socket. But I really, really like Give More Slings. Link for that will be in the description below. At night when you're in bed, if you could sleep on your back, that's great. And just put a few pillows underneath your elbow to keep it up a little bit higher. We call that scaption position. So if you just Google search scaption, you'll get kind of where that position is. That's a great position because it puts most of the soft tissue structures around the shoulder on a little bit of slack. So love that position if you're a side sleeper. My strong recommendation is you don't sleep on your painful shoulder, which probably a lot of you aren't doing. But when you're sleeping on the opposite side, you have pillows in front of you with that arm supported. And then also along the lines of positioning, that caregivers are really very careful when putting a shirt on, when washing under your arm, that they're not moving that arm too aggressively and they're not increasing pain in that arm. That can facilitate more learned non-use or pain, what we call pain avoidant behaviors, which means you'll just subconsciously stop doing certain movements if you associate those movements with pain. So caregivers, just be very careful when dressing and bathing, when you're moving that arm. Try not to move it too fast, because even if someone has a lot of spasticity and maybe they don't have complex regional pain syndrome, that spasticity, the faster you move it, the more those muscles are going to contract. Our brain doesn't really understand what that is, so it'll feel that resistance, which can be interpreted as pain, which means you're going to turn up the volume on that alarm signal, or your brain is. So if you're a caregiver, just make sure if someone has a lot of spasticity, that involuntary pulling in, that you just move the arm slow so that you're not making that contraction stronger. And this one's really important. This is where physical therapy can become valuable, or is valuable, is scapular mobilization. So the scapula is that flat bone on the back. I've done full videos on this, but a lot of times it's stuck. And so when you go to move your arm, it's getting stuck moving. So if you notice that your shoulder blade is down or your shoulder is down and forward, you want to really be stretching that shoulder back, stretching all the structures out on the front of that shoulder. For most shoulder pain, I will say, getting everything on the front of that shoulder stretched out will help with a ton of pain, but also to help with that scapulohumeral rhythm that I talked about earlier, getting that scapula and that shoulder blade to move really nicely. If you can work with a physical therapist, I highly recommend an orthopedic physical therapist. So I know a lot of you are looking for that neuro guru, but I would say most post-stroke shoulder pain, outside of like something spasticity related or complex regional pain related as a result of a stroke, that there's a whole clinical practice guideline for that maybe an orthopedic physical therapist might not be fully confident with. But most post-stroke shoulder pain, I almost recommend an orthopedic therapist. They are a lot more experienced and skilled and done a lot of continuing education and joint mobilizations that I think can be extremely valuable. In addition to, most of these are more in the orthopedic bucket. And like I said, in the neuro bucket, they're going to default to like spasticity and start doing all kinds of things when maybe it's not spasticity related at all. I really do, if you can find an orthopedic therapist that's comfortable working with someone who has a neurologic condition, we kind of get in our silos sometimes and we think that we can't work outside of that. But I do think an orthopedic therapist is probably even more skilled than a neurologic therapist if it's frozen shoulder or an impingement or a bursitis. Back to the recommendations for today, stretching out everything on the front of that scapula, very, very valuable, and stretching towards external rotation. External rotation. Remember, when it's internally rotated, you're only going to be able to get your arm so high when the arm bone is internally rotated. That is why I love, love, love the shoulder flex. For those of you that missed the announcement, we now have a store. We sell the shoulder flex in the store. The only reason I'm bringing it up, the only reason I sell it is because it is the only tool on the market where I really think you can get that true external rotation stretch. Again, I've been promoting it on this channel for a while. I reached out to the company a few years ago because I found it so valuable to really almost double or triple your physical therapy time, because you can go into physical therapy already having that external rotation stretched out. So link to visit our store, because we now sell it in our stores, in the description below. But external rotation, super important. And weight bearing. Weight bearing can help with spasticity. It can help a little bit with the complex regional pain syndrome, but definitely can help with that subluxation. Now, if it is CRPS, I will tell you most of the patients that I have that have CRPS can't really tolerate it. So just do what you can. Maybe you can't put your full body weight on your hand, but maybe you could sit and kind of lean onto your elbow a little bit just to start exposing that shoulder to that weight bearing or that force pushing up through the arm. Again, I've done full videos on complex regional pain syndrome and how to progressively expose a painful area to movement. That's extremely important and valuable when it comes to decreasing your pain and getting more confident that you can move the arm and not exacerbate the pain. And then this last one, which I don't think you guys are doing enough, a lot of you, is assisted movement. Why is this so valuable? Because when your brain thinks it needs to work, for several reasons, when your brain thinks it needs to work really hard, you automatically, your spasticity will kick in, you'll compensate, you'll elevate that shoulder, might even internally rotate. When you're assisting it with your other hand, you're going to be less likely to do a lot of those compensations. So I cannot stress it enough. Active assisted movement, in particular, laying down. Why? Because you're going to do less of all of those compensations. More importantly, it positions your shoulder blade in the right position, which that in and of itself can decrease a lot of more of the structural orthopedic root causes of pain. Now remember, these are just generalizations. I've done full videos on every single one of those root causes, and actually this has me thinking I will create a playlist for post-stroke shoulder pain, and I will link it in the description below so that you can see all of the other videos that I've made on each one of the root causes that I went through today. But as I wrap up this video, the most important takeaway message that I hope you get from this video is that pain is not a diagnosis. Pain is a signal that something needs to be investigated to get to a diagnosis. And medications may help to get you in less pain so that you can get to the root cause, but they should never be a first line of treatment. If you know someone who is struggling with post-stroke shoulder pain, either in your support group or in an online group that you're in, the best thing that you can do to help that person is share this video. I cannot stress enough how often this condition gets mismanaged, and it is just would be so valuable to someone to give them hope, to know that there are options, and to kind of point them in the right direction to start getting out of pain. Now, if the shoulder flex is something that you're interested in, or you're interested in any of the resources that I talked about today, all of those links will be in the description below. If you are someone who feels like you've just plateaued in your rehab in general, and you want access to my entire vault of exercises that I give to my patients that I see in person, and you want to interact with me throughout the week via our Ask Me Anythings, our webinars, and our activity feed that's for members only. Head over to rehab-hq.com and check out our membership programs. If you're having trouble deciding which membership program is right for you, to schedule a discovery call, we're happy to listen to you and help you make a decision as to whether or not one of our programs is right for you. I enjoyed spending time with you all today, and I'll see you in the next video. Have a good day.